Good afternoon, everyone, and welcome to Medical Grand Rounds. I'm your host for today, Lakshmi Santosh. I'm filling in for our good department chair, Dr. Bob Wachter, as he is downtown running his management of the hospitalized patient course today and the rest of this week. We have a really great Grand Rounds for you today, which is our typical clinical problem-solving case, where we have an expert discussant really discuss the twists and turns of clinical reasoning about a case. Our discussant is completely blinded to this case and does not know any details of the final diagnosis. And really, our goal together is to learn from the thought processes of this master clinician, not necessarily to get the quote right answer. Because as you know, they're not magicians. We don't have to know everything. It's all about the diagnostic journey that we'll take together, not the outcome. And we encourage you all to actively participate, engage in your own clinical reasoning while this case is going on. This is going to be fun. And we have a special twist at the end with some teaching by some distinguished Department of Medicine members who are going to give this a little bit of a bench to bedside flavor. So buckle up because it's going to be a fun hour ahead. I am very honored to introduce our expert discussant for today, who's Dr. Lisa Winston, Master Clinician and Professor of Medicine in the Division of HIV, ID, and Global Medicine at ZSFG. She's also the Chief of the Medical Staff and the Hospital Epidemiologist at ZSFG. And she works with the California Emerging Infectious Disease Program as the PI of a multi-site C. diff surveillance project supported by the CDC. She's also a member of a steering group for the CDC's Healthcare Associated Infections Community Interface. And she has a long-standing interest in graduate and undergraduate medical education, has been an outstanding teacher, inducted to the Academy of Medical Educators, as well as the Council of Master Clinicians. And she is a veteran to these CPS problem-solving cases, whether it's here at Grand Rounds or in the New England Journal or at ID Week or anything in between. So we're very honored to have you here, Dr. Winston. Thank you so much.
Thanks so much, Dr. Santosh, for the wonderful introduction. Yeah, always feel a little bit nervous before these, but as you say, they should be fun, hopefully for everybody.
That's exactly right. Thank you so much. We appreciate you. We'll go to the next slide, please. So let's get started with the history. First, before I start, I want to give a big kudos and credit and shout out to our UCSF Parnassus chief residents, Dr. Anna Fretz and Dr. Vidiana Garcia, who've prepared, selected, and chosen this fantastic case and arranged this plethora of amazing mystery discussants who are going to take us through their teaching points in addition to Dr. Winston. So thank you so much, Dr. Fretz and Dr. Garcia. So the history. This is confusion. We have here a 54-year-old man with no significant past medical history who was found walking around confused by EMS. On transport to the hospital, the patient actually had a witnessed generalized tonic-clonic seizure. The team got some more collateral information from the partner who said that the patient was last seen at baseline when she saw him this morning. And we couldn't really get much more review of systems because of the altered mental status, unfortunately. Our next slide, please. So no significant past medical history, as I've mentioned, no pertinent medications, and no known drug allergies, no surgical history and no known family history. And the patient lives in a remote part of Northern California on a farm with pigs, horses, goats, and dogs, works doing construction and other labor jobs, and has never traveled outside of the US. Hopefully that social history made the ID doctor proud, or at least we did an adequate job. We'll go to the next slide, please. So here we reach our physical exam. We see that the patient has a temperature of 37.6, normotensive at 130/70, not tachy, 64, 99% on room air, breathing with a respiratory rate of 20. And in general, the exam is notable for overall not being in acute distress. HENT, cardiac, lungs, GI, extremity exam are all normal. The neuro exam is notable that he's alert and oriented ×3, moving all extremities, but only intermittently cooperative. And the psych exam is notable that he was agitated, but no rashes or lesions were described. Next slide. The first pass labs that we have so far, we have a white count of 12.2, hemoglobin of 13, we don't have a baseline, platelets of 190, CAM panel, as you see, is largely unremarkable with the normal creatinine of 0.6, and LFTs are largely unremarkable. A UTOX was done that was negative. TSH and B12 were normal. And then the CT head showed a hypodensity in the left temporal region, but no acute bleeding. Next slide, please. Then after the CT, the team obtained a brain MRI with contrast. This actually showed heterogeneous enhancement with mild diffusion reduction of a left anterior temporal mass with some surrounding edema and sulcal effacement, but there was no midline shift. Additionally, there were some irregular nodular enhancements noted along the periphery of this mass with some adjacent meningeal enhancement. So a lot of information. Next slide. So we come to our first stop point for Dr. Winston, which we'd love to hear your approach as a medicine doctor and an ID doctor to a brain mass, a CNS mass. And how does this time course impact your differential? And what might your next preferred diagnostic steps be?
Yeah, thanks so much. Well, these, what a great and interesting presentation. Just to note a few initial things that, caught my attention, and I was jotting some notes as we were going through. So this is a 54-year-old, really quite healthy person. Because, usually when somebody is coming to the hospital with, something that's happened, we're taking into account their past medical history, any medications they may be on, because of course we frequently see complications of medications. And in this case, that is really all not on the table for us in terms of needing to, take that into account, which is relatively uncommon, for the patients that we see in terms of, our internal medicine cases. The other thing that is, very interesting about this is that, as far as we know, the patient was not having any symptoms prior to a very acute presentation. And so, if I did not already, kind of have as much information as you presented, and we didn't have the imaging, in terms of confusion, we would be thinking about things that, tend to present over a very acute period of time. But since we know the patient, has a CNS mass, I think that we're, sort of thinking that probably the seizure is related to the presence of the CNS mass. And it seems reasonably likely that the patient's confusion may be related to having had a seizure and to having a post-ictal state. I wasn't totally sure because the patient was noted to be both alert and oriented ×3, but also intermittently cooperative. It is possible for those things to all be true, but it is a little bit unusual. So so I think at this point we're going to be focusing on the CNS mass, which is in the left temporal region and associated with meningeal enhancement. So the first question, well, what is my diagnostic approach to a CNS mass? So the first thing that we always do is, to review who the patient is. And we've done that a little bit already, tried to figure out, what is the, past medical history? Does this patient have a history of malignancy? Something else that, I might think would be contributing to why they have a CNS mass, because the differential is broad. Of course, the first thing, or one of the first things that we do, which I don't think we'll be doing today, but I would always go down to talk to my neuroradiology colleagues to see what they think about the characteristics of the CNS mass, because that can be extraordinarily helpful in terms of, coming up with a differential diagnosis. I will say that, one of the things that we always think about in infectious diseases with a CNS mass is, do we have an immunocompromised or an immunocompetent patient? And as far as we know, this would be an immunocompetent patient. But there would be some tests that we don't have back yet that, we certainly would want to get. One of those would be an HIV test, which is indicated for everyone and would, really open up our diagnosis if we thought that was, in play in terms of thinking of our differential. The other thing that we take into account is, anything that we have regarding the social history in addition to the past medical history. And it's very interesting that this patient has a history of exposure to pigs, horses, goats, and dogs, but all in the US, not with any international travel. And so that may help us to think about where we might be going. In terms of the time course of presentation impacting the differential, in this case, it might not be that helpful, as I said, given the information that we have now, because the CNS mass can be there for a little while, before the patient presents. So we don't have a sense at this point of, how long it's been there before the patient has, had the seizure. If we had serial imaging, then, I think that might be impacting the types of things a little bit more that are in our differential. So in terms of our next diagnostic steps, in addition to getting a bit more information from radiology colleagues and getting the HIV test, as mentioned, we have a lot of baseline laboratory tests that's helpful. Dr. Santosh, I think, would probably agree that, pulmonary imaging can be helpful in many of these cases, because we do have a number of, pulmonary CNS syndromes. So we would be thinking about that. And I think we would at least be getting a chest x-ray, as we're, thinking about what might be there. Then if it's safe to do so, we will usually try to do a lumbar puncture to get more information about what might be there, and that can be sent for a whole variety of diagnostic testing, which we may get into more as we get to the next stopping point. So I think that those would be, the first sorts of things that, we would be thinking about right off the bat.
Thank you so much, Dr. Winston. I think you've taught us a lot about your approach as both a generalist and a specialist to CNS masses, thinking about who's the patient, are they immunocompromised, what's their HIV status, talking with our colleagues in radiology about what are these characteristics, thinking about exposures, prior imaging, getting a chest x-ray to look for my favorite pulmonary CNS syndromes, and then thinking about the safety of an LP. That is a wonderful place to start. Thank you for taking us on that diagnostic journey. Let's go to the next slide, please. So the team actually first got a CT chest, abdomen, pelvis, which was thankfully negative, no acute pathology, no evidence of malignancy, presumably looking for, was this mass sort of a met from a malignancy or a primary malignancy, et cetera. So this is kind of a malignancy screening, pan scan that was negative. They did get an LP with results as follows. So 80 whites, 750 reds, 38 protein, 100 glucose. And the differential on the whites were 17% polys, 60% lymphs. They also did a video EEG to get at your question of, could this have been a post-ictal state, and to rule out active seizures, and the EEG showed no evidence of seizure activity. Next slide. They also got a robust culture workup. So they got blood cultures that were negative. They also got an RPR that was negative, beta-D-glucan galactomannan. The HIV came back negative. Hepatitis serologies came back negative. Of course, in today's era, a rapid COVID was sent and was negative. And then in terms of parasites, they checked cysticercus antibodies, which were negative. And on the LP, bacterial, fungal, AFB were all negative, as well as HSV1 and 2 and VZV. Next slide. So they actually looked at path eventually. So tissue is the issue. And pathology showed a well-formed granulomata with some marked acute inflammation, particularly in a perivascular arrangement. So interesting twist here when we get tissue, and we'll definitely ask you about your thoughts for that. And this was from, I believe, a biopsy of the mass, which they got. So let's go to our next pause point for Dr. Winston with all of this interesting information. You have a lot of negative bacterial, fungal, viral AFB studies. You have this pathology actually showing granulomatous inflammation. So what is your approach to when you hear CNS and granulomas, as again, a generalist and an ID specialist? And how have the negative studies that we've largely received, as well as this positive path, impacted your differential? And now are there additional studies that you might send?
Yeah, fantastic questions. I'm so excited that we are going to have great learning about this in terms of coming up at 12:30, because we are moving relatively quickly through this case, as you had promised. It is really important to get tissue, in the setting of, having a CNS mass. And that can often be delayed. It can be challenging to get that, depending, on the location, how stable the patient is. And so, I think just to point that out, that was really key here, because honestly, our other studies were very unrevealing in terms of helping us out for what the differential diagnosis is. So again, we aren't getting our radiologists to kind of weigh in on does this look more like a malignancy? Does this look more like an infection? We'll talk about the differential of granulomatous diseases, but most of the time when you're talking about granulomatous granulomas on pathology, you usually have moved out of the realm of malignancy and into infectious and inflammatory realms. So we'll talk about those. But the CSF, it's not normal. There are 80 white cells with a lymphocyte predominance, but with a protein that's normal and a glucose that is normal. So really very non-specific. And then some of the other studies that, have come back negative, very appropriate. We want to make sure, that our studies for, HSV are negative. But I don't think that we had, a big suspicion for those things. So, but good to know that they are substantially less likely because our studies are negative. Dr. Santosh, is it possible to go back just a couple of slides to the diagnostic studies, and then we'll talk about the approach to granulomatous disease? Is that okay?
Absolutely. So let's go back to these slides
with one more forward. Yeah, perfect.
Thank you.
Okay, thanks so much. So, so just in terms of, briefly interpreting these studies. So helpful that the blood cultures are negative, if we were thinking about embolic disease. I am not great at reading MRIs, but I would not have looked at that MRI and been particularly suspicious about, bacterial embolic disease, but, good to think about. In terms of the RPR being negative, syphilis can do anything. And you actually syphilis can cause granulomas, and you can occasionally see, more mass-like lesions, but, that would be a very uncommon presentation. The galactomannan being negative, makes aspergillus somewhat less likely, although, not a perfect test. Also not kind of the host that you would think about aspergillus in. The beta-D-glucan being negative is, helpful for a number of fungi, but just to point out that there are some fungi where we would not get beta-D-glucan, and those would include the mucorales. And in an immunocompetent host, there are some mucorales that I would think about, particularly Apophomyces, Cryptococcosis, which I'm going to guess this patient had a CSF crag, although I do not see it there, and probably a serum crab, but a beta-D-glucan would not rule out a cryptococcoma. And then, as we talked about, the HIV, very helpful. The antibodies against cysticercosis, we didn't have a high suspicion for neurocysticercosis, I think, given both the appearance of the lesion and the lack of travel. And the lumbar puncture, if you're looking at a mass lesion, it's not going to be super sensitive for what might be in there, including bacteria, fungi, and AFB. Okay, so now if we could go forward again, if it's okay, and I will try to briefly answer Dr. Santosh's questions about the approach to CNS granulomatous disease. Being an infectious disease doctor, I am going to take the infectious part first, and then we'll take the other things that can cause granulomas. So in terms of the infections that can cause it, of course, we think about TB and non-tuberculous mycobacteria. I don't have a high suspicion for TB in this case, just given that we don't have any known exposures for it. Usually people with CNS TB disease are sicker. It's more common for CNS disease to present with meningitis, where you would see elevated protein and low glucose, but mycobacterial disease is possible. Fungal disease also possible, and certainly we would want to get cultures for trying to figure out if a fungus could be present there. And then the other thing that we think about in the brain with granulomatous inflammation is amoebic disease. And so, the main amoebae that we think about are Balamuthia and Acanthamoeba. Balamuthia would be more common in an immunocompetent host, and has, for unclear reasons, is more common in folks who are Latinx. And it is unclear why, potentially related to exposures. And then we would also, but Acanthamoeba in somebody who's immunocompromised. Can we bring in our pigs, horses, goats, and dogs? to make this a little bit more interesting. So there are some diseases that we will associate with those kinds of exposures, including brucellosis, associated in this case with the goats and the pigs. Cysticercosis, can be associated with, depending on where you are in the world, pig and dog exposures, but I think it's going to be less likely in this case. Somebody on a farm, we're going to be thinking about Coxiella burnettii as a possible etiology, and then there may be some other things that are going to be even less common, and they may not be immediately coming to my mind. So additional studies that I would send at this point, for the diseases where we have serologies like Coxiella and Brucella, I would go ahead and send the serologies for those. I would likely think about sending universal PCRs on the tissue, which are send-out tests, but we can send for bacterial, TB mycobacteria, non-tuberculous mycobacteria, and fungi. And then we can also send next generation sequencing, which is very exciting and might give us an answer for pathogens that haven't even been mentioned because of the vast array of organisms that can be picked up. And then some of the, of course, we have to think about non-infectious things as well. I'm probably going on too long. So I will just briefly talk about, could this be sarcoid? I think this would be a really unusual presentation for sarcoid, just presenting with CNS disease, nothing pulmonary, none of the more common manifestations, but it would at least cross my mind. I would wonder about some other inflammatory diseases that, are not ones that I have as much familiarity with, that might present with granulomatous diseases. I would certainly have a conversation with pathology about the inflammatory conditions that might be on their differential as opposed to the infectious ones.
What a tour de force of clinical reasoning, Dr. Winston. I appreciate so much how you told us about everything from, don't assume that a negative LP means it's not infectious when you have a CNS mass. We talked a little bit about infections that cause granulomas, as well as farm animal exposures. What bugs do you think about? And rounding out that non-infectious list. This is such great learning. Thank you, Dr. Winston. Let's go to our last couple of slides before we get into a discussion. So ask and you shall receive. We got some additional infectious studies. We have Bartonella, that's negative, urinary histo, that's negative, cocci, both complement fixation and immunodiffusion negative, sporotrichosis serologies were negative. And then of the biopsy of the brain, we have cultures that are bacterial, fungal, and AFB all negative. Next slide. So this is our last stop for you to get the opportunity of, are there any other additional studies that were not mentioned that you would like? You already told us that this might be a good use case, as you mentioned, for universal PCR or next-gen sequencing. But besides those, any other studies? And putting your nickel down, if you can, in the last minute about what do you think the final diagnosis might be, acknowledging that, of course, we've learned so much already. And thank you so much for your time.
Yeah, well, so appreciate the opportunity, to think about this. I think the main additional studies that I would like are some of the ones that were mentioned. There are a few serologies that we should probably round out, like Coxiella and Brucella, that I didn't see on the prior slide. these would be very unusual presentations. To see a mass lesion, when you see granulomas with those organisms, we tend to think about them much more with granulomatous hepatitis than granulomatous brain disease. So, but it's not that uncommon when we have very difficult diagnoses of things in the CNS where infections are on our differential, where our initial studies are negative. So, I'm going to have to put my nickel down on some type of a final diagnosis. And could we go back just one more slide? We gave a lot of these things an opportunity to grow, and bacteria do not always grow, but we didn't get bacterial growth. We didn't get fungal growth. We haven't seen the AFB, a lot of our serologies are negative. And so this does bring to mind cases of granulomatous amoebic encephalitis, as we had discussed a few minutes ago. It's a very difficult diagnosis to make. It has generally been made, on brain biopsy. We usually have to get our colleagues from CDC involved to, help us out. But I think we're going to, and as I said before, if it's an immunocompetent host, then Balamuthia is going to be more common than acanthamoeba in this case. And I will just say there's another amoeba that we think about with CNS disease, Naegleria fowleri, but that presents with a fulminant meningitis, not a granulomatous encephalitis, so or a granulomatous mass. So I think would not be high on our list here. So really hard to make this diagnosis. It's often very prolonged. And then, I look forward to hearing more from the experts who are going to be talking about it. Another real challenge with that is treatment. So even once you make the diagnosis, trying to figure out, how you can help someone get better from it, is also a challenge. So we are at time. I should stop there. And I greatly appreciate the opportunity to hear about this really interesting case.
Thank you so much, Dr. Winston. That was masterful. And I love how you helped us really flesh out our collective illness scripts for CNS masses, infectious causes, non-infectious causes, and even within the infectious causes, getting to know the subtleties of the different presentations of, Balamuthia versus acanthamoeba versus N. fowleri, et cetera. So that was fantastic. And I think we're going to find out that you hit the nail on the head. So next slides, please. So the final diagnosis, as you had suggested, with an immunocompetent host, this patient's UPCR of the brain tissue came back positive for Balamuthia, and the final diagnosis is indeed Balamuthia granulomatous amoebic encephalitis. I am delighted to introduce our expert discussants who are going to be chatting with us today, our three mystery panelists. So we'll have the three mystery panelists turn their videos on, and they are going to share their own screen as well. Hello, wonderful mystery panelists. And the next half hour is going to be a little bit of a shift from the bench to bedside. We're actually now going from the bedside, the clinical problem solving, to the bench and back. So we have we have three panelists here. We have Dr. Joe DeRisi, Dr. Michael Wilson, and Dr. Tash Spottiswoode. So thank you so much for being here. We're going to learn a little bit about the pathophysiology, the biological basis, how this was discovered, and how might we apply the innovative lab techniques noted here to the care of future patients. I'll have you all take it away. Thank you so much for being here. And again, a huge round of applause for Dr. Winston for her amazing clinical reasoning.
Lakshmi and Lisa, that was a tour de force. Can everyone hear me okay?
We can hear you. Thank you.
Beautiful. So my name is Natasha Spottiswoode, and thanks to that very kind introduction, I'm going to be leading our talk today about Balamuthia encephalitis. Our quick disclaimers, Dr. DeRisi and Dr. Wilson have some consultant disclaimers. I have none. I'm going to start with the first question that I had when I first heard about this case, which is, what is Balamuthia and why is it in our brains? Balamuthia was first described in 1990, and the actual first patient was not human. It was a female mandrill at the San Diego Zoo who was found to be dragging her limbs, later passed away, and on necropsy was found to have these unusual cells in her brain that were found to be amoebas. Balamuthia is an amoeba, which is a eukaryote, so it's a complicated life form with more in common with us, genetically speaking, than with bacteria, which means it's hard to kill. It has this tough dormant cyst stage shown here in this video, and this metabolically active moving trophozoite. Now, it's thought to enter our body from the CDC diagram through one of several ways, through nasal passages into the respiratory tract, or through ulcerated or broken skin. And there it causes several syndromes, including skin lesions, pneumonia, disseminated disease, and most typically and most fatally, granulomatous amoebic encephalitis, or GAE. Now, who gets it and why? This is the largest case series to date. This graph shows the number of diagnosed cases in the USA between 1974 to 2016. Remember, it was only identified in 1990, so everything below that is actually a post-mortem diagnosis. And so between those years, there's 109 cases. For reasons that I will discuss, we think this is a really major underestimate given how hard it is to diagnose. But of those 109 confirmed cases, there are 10 survivors. That gives it a mortality rate of greater than 90% and puts it in the top legion of most deadly pathogens. For reasons that are somewhat unclear, there's a slight male predominance, and it affects immunocompetent people of all ages, ranging from little children to people in their 90s. About 20% are children under the age of 5. Now, I think Lisa mentioned something about soil exposure, but there's some thought that we get this from soil. The bug has been identified in soil, and of patients who were asked about soil exposure, most of them report some sort of recent soil exposure, whether workplace or gardening or children playing in the mud. Now, antibodies may or may not be common. This is controversial, but they looked at the antibodies to this bug in healthy controls. It's around 2.5% of the population. But we also don't really know to what extent this test has false positives. So that's still an area of investigation. And finally, it's actually been recorded in transplant cases. There have been 2 case clusters after organs were transplanted from infected donors into recipients who then developed disseminated disease. So that's who it affects. I want to say that oftentimes I bring up Balamuthia and people say, I've heard about an amoeba, but not that one. The better known cousin of Balamuthia is Naegleria fowlerii, and the other one is a Canthamoeba species. Naegleria causes this very fulminant, dramatic syndrome called primary amoebic encephalitis, or PAM. It's fulminant, it affects immunocompetent people, and the typical story is a young person who's been swimming in warm water, like a lake in the summer. In fact, there were several cases this summer. It enters through the olfactory epithelium, so you can also get it from neti pots, which are used for sinus rinses, and then it causes this very dramatic and very, very often fatal disease. There's been about the same number of Naegleria cases in the last few decades as there have been Balamuthia. Acanthamoeba is rarer. It causes the more progressive granulomatous amoebic encephalitis, or GAE, and it affects largely immunocompromised patients and also causes a keratitis in people with contact lenses, which strikes fear into my heart. It is found in water and soil, as they have all been identified in soil, and it gets in via the skin or respiratory tract or eyes. And then finally, as we discussed, we have Balamuthia causing the slightly slower granulomatous amoebic encephalitis and found in soil. Now, I'm going to talk a little bit about why making this diagnosis is really hard and why I'm even more impressed that Lisa got there so very quickly. So first of all, when patients come into the hospital with a brain mass, with signs and symptoms of a brain mass, we get images of their head. But the imaging findings of amoebae are very non-specific. Patients are usually misdiagnosed with something like a malignancy, with TB disease, with bacterial brain abscesses. Usually people don't think of amoebae. You can diagnose it based on pathology, but unless you have a very experienced pathologist who's seen this before, it usually requires special immunohistochemical or indirect immunofluorescence staining. And of course, it requires a brain biopsy, which is probably the most invasive diagnostic test that we have. Can you diagnose it based on CSF? Usually no. CSF findings are nonspecific. You get an elevated cell count, monocytic or lymphocytic. Protein can be normal. Glucose can be normal. Very rarely and somewhat alarmingly, there's been descriptions of the organisms being seen swimming on the CSF microscopy, but this is pretty darn atypical. So you can send CSF to the CDC, where they have a multiplex dedicated PCR for amoebae, Balamuthia, Naegleria, and Acanthamoeba. And the CDC also has access to serological tests, but these are not used frequently, as there's a lot of concern for false positives. But I want to really highlight that in order to make this diagnosis, you have to think, I wonder if this is an amoeba. And if it is, if I think this is an amoebic disease, I may get a biopsy, send samples to the CDC, send CSF to the CDC. But these are all things that require the treating clinician to first envision the diagnosis. And very, very, very few clinicians have an illness script for this disease because it is so very rare. So this is a disease, as other rare CNS diseases are, where there is a large and growing role for what I call unbiased diagnostics. And it gives me great pleasure to introduce and hand over to Michael Wilson, who's going to talk a little bit about unbiased diagnostics. Take it away, Michael.
Okay, thanks so much. So I'll just giving a quick primer here on a technique that there's been a whole beehive of activity around at UCSF for a number of years now, which is a metagenomic next generation sequencing. And so in the first slide here, this is just a pictorial illustration of the whole range of pathogens that can cause neurologic infections, of course, systemic infections as well. And as Dr. Winston really nicely highlighted, there are a series of candidate-based tests that we send off on spinal fluid and other tissues to rule in or rule out particular pathogens, whether it's a pathogen-specific PCR, a serology, an antigen test. But of course, sending those tests is, as Dr. Spottiswoode said, is dependent on first having that pathogen in your differential diagnosis and prioritizing it highly enough to test for it in the limited spinal fluid volumes that we typically work with. So we know that there are limitations to this approach. And so if we go to the next slide, the work that's been done here for a number of years is focused on taking a different tack with regard to picking up unusual and unanticipated infections. And the idea there is, instead of going in with primers that are specific for herpes simplex or some other pathogen, rather going in with primers, millions of primers that are random, so that you can amplify all the genetic material in a sample, whether it's spinal fluid or respiratory fluid, blood, brain tissue, and then computationally analyzing those sequences that come out, specifically the sequences that do not align to the human genome, and identifying which pathogens best match the sequences that have been generated by the next generation sequencing technologies that have become so prevalent over the past decade or so. So if we go to the next slide. So this was a case of Balamuthia meningoencephalitis that your very own Mike Reed, I think, worked on as a fellow, and was a patient at San Francisco General Hospital. This was a 74-year-old woman living in San Francisco. And she had 3 hospitalizations before coming to the general. The first was for what turned out to be a Klebsiella UTI. The second was for an endophthalmitis that caused an acute monocular vision loss, which was thought to be either due to Klebsiella or toxo. The third was for incidentally discovered strokes, thought to be due to a cardiobolic etiology in this context of newly diagnosed AFib. And then the fourth presentation was for coma, when she came into San Francisco General and had this MRI, which shows this is a T2 flare sequence where you can see numerous T2 hyperintense lesions. And unlike the case we're discussing today, you'll note that there is an abscess on the actually in both ventricles. So in this case, unlike the first case, there's rupture of the abscess into the intraventricular space, spilling the contents, the pus, into the CSF. We go to the next slide or the next line. And so she also had an extensive workup, including 2 brain biopsies, and failed to have a diagnosis. You can go to the next. And in the course of her hospitalization, where she was in the ICU the entire time, she received a huge range of antimicrobials to treat possible fungal, bacterial, parasitic, mycobacterial infections without any clinical improvement. Go to the next. And so she ultimately died, and we had the chance at this point on a research basis, when I was a postdoc in Joe's lab, to sequence the spinal fluid from this case and identified Balamuthia. Thank you.
Thank you so much, Michael, for going through that. I think that that's a great summary of why diagnosing this is hard and the potential role that unbiased diagnostics, especially metagenomic next-gen sequencing, can play in the diagnosis of rare diseases that don't fit into our illness scripts. I want to take a minute and switch gears and talk about another difficult area of Balamuthia, which is treatment. As Lisa alluded to, not only is diagnosing Balamuthia hard, but treating it is also very hard. This is a disease that is so rare and so deadly that there has never been a randomized control trial in this case, and I don't think that one will be possible. Everything we know about treating it comes from survivor case series, so what people who happen to have survived the disease were given. The newest addition to the regimen is a drug called miltefosine, which is used for leishmaniasis, which was used in 3 out of 11 survivors. And the overall regimen consists of miltefosine, azithromycin or clarithromycin, sulfadiazine, pentamidine, fluconazole, and flucytosine. Now, that includes 2 antiparasitics, 2 antibacterials, and 2 antifungals. It's had inconsistent results. There's not a lot of data on precise proportions, but over 50% of patients still do not make it. And as well as having inconsistent results, it also has really marked toxicity. Basically, the guidance is start all of them and keep on them as long as you can, as limited by the toxicity of agents. In particular, pentamidine, sulfadiazine, and flucytosine are really, really difficult for patients to tolerate. So in a disease that is this rare, where randomized control trials are infeasible, how are we going to advance care and how are we going to reduce that terrible mortality? For this, I would like to introduce Dr. Joe DeRisi, who will tell us about his lab's efforts in this regard.
Thank you. Dr. Wilson and I were frustrated by that earlier case in 2015, realizing the complete dearth of therapeutic options for Balamuthia. They're depicted on the left, growing in our laboratory, cleaning the plate clean of human cells, which are on the left side there with the feeding buffet in the center. So we can grow Balamuthia in the lab. It grows on human cells orogenic. And so we took it upon ourselves, because there will be no commercial interest, there will be no clinical trials, to look at approved drugs. Next point. So we looked at a collection of over 2,000 FDA or internationally approved drugs, reasoning that if there's something in the arsenal we can use now, that might be a way to go since we can't develop anything new. Next point, we assessed growth inhibition. Can we stop the bugs from growing? Can we protect human tissue, brain tissue, in this case, fetal brain explants, from destruction by the bug, not just stop them growing? And finally, can we either promote the bugs to insist, which will give the immune system a better chance to fight them, and can we kill those cysts? We conducted this screen here at UCSF. Next slide. And of all the compounds that we screened, really only one candidate emerged. On the x-axis, you can think of that as a z-score, and on the y-axis is percent inhibition, so being in the upper right-hand corner is where you want to be. Those green dots are topical antiseptic or veterinary drugs, not appropriate for humans. The blue dots are the recommended CDC regimen, and you can see they're down in the left corner for the most part. Nitroxyline was the only compound that emerged as a lead candidate here. It is a quinoline. Next point. It's been used for over 50 years in Europe for UTIs. Next point. It's orally available. As you can tell, it's a very small molecule. It's got an excellent safety profile with decades of data. Next slide. Its known mechanism of action is likely as a metal chelator, although the exact mechanism of action against bacteria is a little unclear. Next slide, next point. And while the IC50 against Balamuthia was about 4 micromolar, the adult concentration max in sera in many clinical trials is up to 30 micromolar. And this presents a real wide therapeutic index for this compound to act. And so we published this compound on the hopes that someday someone might notice it.
Well, thank you so much, Joe. I really appreciate it. I'm going to take us back to the case and describe what happened. So this graph here starts with our patient the day he first arrived, and the gray bar shows days since first presentation. He was diagnosed on day 26. The diamonds refer to MRIs. And at that point, we called the CDC and we started him on the 6-drug therapy. So that's pentamidine, sulfadiazine, flucytosine, azithromycin, fluconazole, miltepacine, and we also included albendazole, which had also been used in some case studies. Now, initially, we saw some improvement in lesion size by MRI, but we rapidly ran into toxicity. Pentamidine caused refractory and life-threatening hypoglycemia and had to be permanently stopped. Sulfadiazine caused renal calyx sloughing, resulting in acute renal failure, which resolved with stent placement. That had to be permanently stopped. And flucytosine caused severe bone marrow suppression and had to be stopped several times and then dose reduced. So we wound up with about 4.5 drugs that he could be on. And on that regimen, the lesions began to enlarge. At that point, we discussed with the patient, his family, and all the teams that our prognosis was very limited and that we had to make the choice to seek new therapies. And that is when we contacted Joe DeRisi. So we set about trying to get nitroxyline. Let me tell you about the process of obtaining a novel medication, which is not available in the USA and is not approved for this indication. If day 0 here is the day that we saw the MRI and made the decision to get nitroxyline, we immediately, by day 1, had applied for what's called an emergency investigational new drug authorization, which, as I found out, is basically going to the FDA and saying, we think this drug may work for this disease, which has a very, very high mortality rate, and we need approval to use it. I will say the FDA hustled, and when it was clear that we were going to be able to get the medication, we formally consented the patient and his family, and by day 8, the FDA had approved our EIND. We partnered with the international pharmaceutical company. Again, this drug is not available in the States, called Asieris Pharmaceuticals, who had to package the drug, prepare it, and ship it to us. It was shipped on day 30. It arrived on day 32 by FedEx. And on day 41, the first dose was given to the patient. So even with everyone sort of hustling as much as possible, this took over a month. And during that time, the lesions were growing. So I think the next question is, what happened? Did it work? I will show you, over here are the MRIs from the pre-nitroxyline MRI when the patient was on the 4.5 drugs that he could tolerate. And next to them is an MRI showing the scans 7 weeks after the addition of nitroxyline to his regimen. Now, we have the luxury of having a neurologist on this call. So Michael, could I possibly ask you to interpret these MRIs for me?
Absolutely. So the top 2 MRIs are post-gadolinium T1 images. So these what's lights up on a post-gad T1 are areas of blood-brain barrier breakdown where the gadolinium has leaked into the brain tissue, and you can see in the left frontal lobe in the pre-nitroxyline MRI that there's a nodular ring-enhancing lesion with some dark areas around it that are bright on the T2 scan below it, showing that there's a great deal of edema around that abscess. Similarly, you can see on that T2 scan in the bottom left that there's also edema in the right cerebral hemisphere. And then in the post-nitroxyline treatment images, you can see that abscess in the left frontal lobe has markedly decreased in size, and that that bright T2 signal in the bottom right-hand corner is much smaller in the left frontal lobe and is essentially gone in the right hemisphere as well. So there's been kind of marked decrease of enhancement and surrounding edema in multiple lesions.
Thank you so much, Michael. I appreciate it. I will say a repeat MRI 17 weeks post-nitroxaline continued to show improvement. How does this case end? This shows the entire duration of the patient's treatment. The MRIs shown here in blue are the ones that you just saw. The patient has been kept on the 4.5 drugs of the primary regimen that he was started on, and he continues on nitroxaline. He does have sequelae from his illness. He does have residual deficits due to the amoeba, but he is alive and he is living in the community at 15 months. I think he is very much on his way to being one of the survivors of this disease. So what can we take away from this? I'd start by saying that diagnosing Balamuthia and other rare and deadly infections is hard, but we also need to diagnose it quickly to get started on treatment. And that's where I think unbiased diagnostics like metagenomic NextGen can be incredibly useful if we have an unusual infection. I urge anyone who has an amoebic case to reach out to experts early for assistance. The CDC number is here for the Free Living Amoeba branch. They were extraordinarily patient, kind, and very helpful in this case, and I would urge anyone to reach out to them. And finally, a word on treatment. This is a case study. It has all the limitations of a case study. That said, this is a disease that is extraordinarily deadly, and for which the usual regimen is not based on randomized control trials, works inconsistently, and is very toxic. I think based on the in vitro data that the DeRisi lab has produced and our clinical experience with this case, that nitroxaline may be a promising addition for patients with Balamuthia. As it stands, Balamuthia encephalitis is one of the most deadly and devastating diagnoses that we can give to any patient and their family. Our hope is that this helps to change that. I want to say as my last thing that this case requires sort of extraordinary bench-to-bedside collaboration with basic scientists of the sort that UCSF promotes and that I am proud of. It required extensive teamwork from very many clinical providers, and it required forging partnerships and asking for help from outside institutions. I'd like to acknowledge a few people. I'd like to acknowledge all of the clinical teams that worked on this case, the CDC, the FDA, the drug company, the research teams of Joe DeRisi, Michael Wilson, and Charles Chu, and most of all, the patient and his family. Their courage and resilience in the face of this diagnosis is inspirational, and it has been my privilege to work with them. Thank you all so much for your attention, and in the few minutes remaining, I will happily take any questions.
That was truly a true to force. What an hour. Dr. Spottiswoode, Dr. Wilson, Dr. DeRisi, and again, circling back to Dr. Winston and Dr. Garcia and Fretz for preparing this case. And of course, importantly, to our patient and family who allowed this all to be possible. I loved how you took us through this inspiring journey throughout this hour, from the clinical reasoning, learning about CNS masses, thinking about amoebae early on in our differential, and thinking about different illness scripts, to thinking about why diagnosis can be so difficult, and thinking about ways to enhance our diagnostic armamentarium with new technology, and then sharing your tale of the collaboration between science and industry, all taking it back to the patient, was truly outstanding. So this was an incredibly rich teaching case. I'm curious for Dr. Winston first, any reflections as the case unfolded or based on your prior clinical experience with CNS amoebic infections?
Thanks. You know, I remember that case from 2015, so devastating. I think I was selected as the consultant for this case because so many people were aware of it, and I had not heard about it. But I just have to say, I'm so excited that, you know, if this happens again, that we may have something better to offer, not something I had heard about before. And so that's just fantastic.
Thank you so much, Dr. Winston, for your reflections. A question from the audience that we have is, you've outlined to us this amazing process, how you went to the laboratory, screened for this compound, nitroxyline, and then eventually used it in your patient. Is there a process to get this drug for other patients in the US or beyond?
That's a great question. And I can take that if it's all right. So I'd say, given our experience, Joe has, I will say, we put this paper online as a preprint. And without giving any details, I'd say we've been contacted since putting it online by multiple teams who are caring for Balamuthia patients. I will not give any details about their cases, but I will say that we are helping them to figure this out. We have also communicated our findings and our experience directly with the CDC.
Wow, that is really powerful, taking your findings and helping other patients in need. Dr. DeRisi or Dr. Wilson, any final reflections?
I think the tissue is the issue is a really important point here. Unlike the 2015 case, there were not amoeba in the CSF. And while the clinical metagenomic sequencing is approved for CSF, it is not yet approved for tissue. We did retrospectively analyze the tissue by metagenomics, and it was positive for Balamuthia, indicating that we also need additional tissue types to be CLIA approved for metagenomics.
Yeah, and I would just echo that, just in general for brain abscesses, if they haven't ruptured, just any direct detection test on CSF, whether it's culture, PCR, or MNGS, universal PCR is always going to be less sensitive than looking at tissue. But that 2015 case is, is a nice contrast. Once there is CSF exposure, that those tests can be much more high yield.
Thank you. Huge thanks to Dr. Spottiswoode, especially for corralling our team of experts, Dr. Winston for her fantastic teaching, Dr. Fretz and Garcia for finding this case, and Dr. Wilson and Dr. DeRisi for their scientific expertise and clinical expertise. Thank you all for tuning in, and please join us next week back for Medicine Grand Rounds. We're going to be talking about cardiogenic shock. Appreciate you all.